Assalamu alaikum and welcome to another video of Learn with Larib. I hope you liked the previous video on limbic system. Today we will be discussing the midbrain. Midbrain is a part of mesencephalon, so the embryonic component is mesencephalon. It's present between the pons and thalamus, and two major cranial nerves, the cranial nerve 3 and 4, arise from the midbrain. So the midbrain is composed of crus cerebri, tegmentum, and tectum. The crus cerebri is basically the fibers, which are the motor and descending fibers, the descending motor tract, containing of corticospinal and corticobulbar fibers, as well as corticopontine fibers. So medially, we have the corticospinal and the corticobulbar fibers. Laterally, we have the corticopontine fibers. This is an important area with respect to the lesion, which is quite commonly tested on exam, that is Weber syndrome. We will discuss about this later. The tegmentum consists of the cranial nerve nuclei, which are for cranial nerve 3 and 4, as I just mentioned. It also has the red nucleus, which is associated for the rubrocerebellar pathway and the motor coordination. So this gives us a rubrospinal tract and is also coordinating with the cerebellum. It also has substantia nigra, which is again a part of basal ganglia. So substantia nigra is a dopaminergic pathway we discussed in the previous video, as well as basal ganglia. The reticular formation, this is a very important point. The reticular formation is in the midbrain, which is associated with your arousal after sleeping. We will discuss this later in the video. It also consists of the ascending tracts, which are the spinothalamic and the dorsal column medial lemniscus pass through tegmentum. So the crus cerebri have descending motor tracts, the the corticospinal, corticobulbar, and the corticopontine. Tegmentum has the cranial nuclei, red nucleus, substantia nigra, reticular formation, ascending tracts. The tectum over here consists of superior colliculus and inferior colliculus. Now, this is a very important point and this is very high yield. It is asked again and again on your exam. The superior colliculus is associated with vision and the inferior colliculus is associated with auditory signals. And again, this is very important. So this basically, the superior colliculus associated with the vision coordinates the eye and head movement towards the visual stimuli, and the inferior colliculus relay the neuronal signals from the cochlear nuclei to the medial geniculate body, which is present in the thalamus. So in thalamus, the medial geniculate body was associated with hearing. In midbrain, it's the inferior colliculus. These two are related as well. However, here the superior colliculus related with vision is not associated with the lateral geniculate body directly. It's responsible for the head movement and eye movement towards the visual stimuli. Now, coming to the blood supply is not directly asked, but we will do this in detail also. But the basic blood supply is posterior cerebellar artery and superior cerebellar arteries. So you're often is tested on the ischemic area, and it becomes difficult to learn it all together. So I'm just hinting the blood supply here. So when we do it in the blood supply of brain topic, we are able to just, remember it. Now, coming to the syndromes, as I just mentioned in the start, the Weber syndrome is important and high yield. It is associated with the crus cerebri. In Weber syndrome, there is a lesion in the crus cerebri and the cranial nerve 3 fibers, which are the oculomotor fibers. This one is due to the blockage of posterior cerebral artery. Again, this is a high yield part and this is also associated with the blood supply clinicals. So if there is any occlusion or stroke or any infarction due to paramedian branches of posterior cerebral artery, it will result in the lesion in crus cerebri and cranial nerve 3 fibers, resulting in Weber syndrome. So crus cerebri, as I mentioned, contains the corticospinal, corticobulbar tract, and the lesion will result in hemiplegia of the face and limb. Since this will be contralateral face and limb hemiplegia along with ptosis down and out eye gaze. The gaze will be down and towards outside, and there will be dilated pupil. This is very clearly a loss due to a loss of cranial nerve 3 fibers. So both of these symptoms together is the Weber syndrome due to PCA. The Benedikt syndrome is due to a lesion in tegmentum of the brain. Again, this is due to the paramedian branches of posterior cerebral artery, and the red nucleus and cranial nerve 3 along with medial lemniscus are lesioned in this syndrome. So this will then result in, again, ipsilateral oculomotor palsy, which results in these symptoms along with contralateral tremor and ataxia. So this was important for coordination and balance. The red nucleus controls the rubrospinal pathways, so it plays a side role in coordination. And if there's a loss, it will result in tremor and ataxia. And then if there's a loss of medial lemniscus, which is a sensory pathway responsible for touch and proprioception, contralateral loss of touch and proprioception. So Ben, if you see tremor, ataxia, cranial nerve 3 symptoms, and sensory loss related to touch and proprioception, it will be Benedikt syndrome. The Claudi's and Parinaud syndrome are not very important. The Claudi's is again due to tegmentum involving red nucleus and superior cerebellar peduncle, and this will be tremor and ataxia but no sensory loss. So as I said, it involves the red nucleus, the superior cerebellar peduncle, not the dorsal column or anything else. The Parinaud syndrome or the dorsal midbrain syndrome involves the tectum. Now tectum consists of superior colliculus and inferior colliculus. It will involve the superior colliculi and the pretectal area. This can result due to hydrocephalus or multiple sclerosis, and the structures damage will result in vertical gaze as superior colliculus is involved. The pupil will react to accommodation, but there will be a loss of light reflex. So loss of light reflex, but the accommodation reflex or accommodation is still possible. So if you come across these symptoms in exam, the lesion will be in tectum of midbrain. Now there is a high yield point over here which often comes in MCQs. They ask you that there is a loss of light reflex, but the accommodation is intact. Where is the lesion? The answer will be pretectal area of the midbrain. This is an MCQ and it often comes in the exam. So we discussed the midbrain, the blood supply, the parts of midbrain, the two cranial nerves, and the syndromes. I think this is enough for today. I will discuss sleep physiology in the next video. Thank you.